opportunity. Most respected Chairman, IMA Academic Committee, Professor M.S. Ashraf Sir, Convenor, IMA Tamil Nadu State Branch Academic Committee, Dr.V.Aruljothi Sir, State President, our IMA State President Tamil Nadu, K.M. Abdul Hassan Sir, Honorary Secretary, Dr. S. Karthik Prabhu Sir, and Honorary Secretary, Finance Secretary, Dr. Gauri Shankar Sir. And dear delegates and esteemed members of the IMA of Indian National Association. So it is a great pleasure and honor for me to chair this wonderful session, and it's going to be delivered by Professor Dr. M.Natarajan. He is going to talk on what is unseen in the investigations. We know the two eyes, but what is the third eye? Third eye means what is left is seen is the third eye, and we are in the era of the innovative medicine, artificial intelligence, and interventions, all innovative interventions. But still, if we apply clinical medicine and basic investigations, we can be par with artificial intelligence and innovative medicines, whatever is going to come in future also. Such a wonderful this particular session, and it is going to be delivered by a great physician, the clinician par excellent, none other than Dr. M. Natarajan, who was graduated and the entire service as a tutor of medicine, assistant professor, associate professor, head of the Department of Medicine. Everything is in the Madurai Medical College, Rajaji Government Hospital, Madurai. And he was the scientific committee chairman for almost all annual CME which occurred in the Madurai Medical College. And he was a quiz master in the South Zone Epicon conducted in 2013, and many poster presentations in Epicon serially. And he is trained in echocardiography. Sir is very much a popular speaker in all national forums and international forums as well. And he was a postgraduate teacher since 2009. And of course, he is participated in several trials, and he also is participated in the trial of plasma paralysis in COVID time. And he's a great physician. He's a principal investigator of the COVID-19 epidemic and treatment protocol. And he's one of the best teacher, speaker, clinician, and by and large, is a great human. He is a wonderful speaker. We are very much blessed to have our professor, Dr. Rajaji, with us now. We will be talking about what is not seen in basic investigations. Now over to the speaker.
The person who takes medicine must recover twice, once from the disease and once from the medicine. Now, if at all, if he has lived in this era, I think he'll add a third thing. The person should also recover from the debt incurred for his investigations, because we know all the investigations are very costly and we don't interpret it properly. So we go on adding on investigation, adding burden to the patient. So now I'll take through simple investigations and where we have to concentrate much to clinch the diagnosis. With that few introduction, I'll just proceed with my presentation. So what is the third eye, as rightly pointed out by my friend, chairperson, Professor Paranthaman sir? It's an astute property of a physician. So of late, due to many factors, it has become vestigial. That is the main thing. So we just rush through the investigations and we don't actually concentrate on investigation. We don't apply our mind to the investigation to clinch the diagnosis. So now we should be able to diagnose the case even if the investigations have been told to us without seeing. That means our actual eyes are less important when compared to our brain. So that is what I'm going to highlight today. And certain examples in what are the errors we do in the investigation. Errors can be in the from the patient or from lab side. That is entering the patient details. So the basic thing is first you find out whether it is your actual patient, what is the age of the patient, what is the sex of the patient. You confirm and then proceed with the investigation reading. And error in processing the required tests. That is also very, very important, because certain or most of the investigation, better do it immediately. Once you collect the sample, you transport to the lab, or the lab should be within your premises, so that the undue delay in the processing may affect the results. So particularly when you are going to do ABG or ammonia or even sugar, if there's delay in the processing, you will have a spuriously low sugar value. And third is the error in collecting the sample. That is also very important, because you should not draw sample when there's IV line flowing through it, or you should not squeeze the muscle too much. There will be rhabdomyolysis, also there will be hemolysis, and then you have spurious hyperkalemia. So these are all very simple things which all of us do know. But now today I'm going to concentrate on error in interpreting the result. So that is the main purpose of this today's meet. So this is one thing. So like reading in between lines, if you see this, if you see actually superficially, you are able to see white pillars. But if you concentrate and you go in depth of the picture, and if you concentrate on the blacker side, the darker side, you can see two human beings. They are facing each other. I think you can appreciate that. So if you concentrate on this black, they are so some of us we are very happy seeing only the white pillars, but in investigation you have to see the other side of also. And this is again, if you are seeing only a mat, but if you see carefully, you can see a figure in it. You can figure out a figure in it. That is an Albert Einstein figure. So this is what which I'm going to highlight today. Though the same investigations, which is read properly, will throw more light. So I'll take you through some case scenarios wherein we can concentrate much on the in-depth of investigations. I'm going to take only simple investigation, not complicated investigations at all. So this is a case of 39-year-old male who has come with fatigability, he had anemia, and he was having this anemia right from 20 years or 25 years of age. That was the first time he was diagnosed with this anemia. And so he was going from doctor to doctor to find out the cause for his anemia, but he was not cured at all. And when you go through this automated hemogram, his hemoglobin was 8.8. That is very clear, no doubt. And whenever you got a hemoglobin, nowadays you don't ask only for hemoglobin, ask for an automated hemogram, preferably a 5-part, which is available in most of the modern labs. That's not very much costly. And then you look at the MCV. You know, this is the MCV. Sorry. MCV is low, around 50, 57. So we classify anemia into microcytic anemia, normocytic anemia, or macrocytic anemia. If the MCV is between 75 and 95, it is normocytic. Here it is 55, 57. So if it is 57 MCV, almost always the commonest diagnosis is iron deficiency anemia. So the first physician has made a common diagnosis looking superficially at this automated hemogram as iron deficiency anemia, and he has started the patient on iron supplements, but it was refractory to therapy. And so he has done all the investigations for iron deficiency anemia because his third eye has not opened. He has seen only iron deficiency anemia with his eye, and he has done 4-bit is now the best investigation, that is fecal occult but immunochemistry test. That is commonest cause for iron deficiency anemia in an adult male, unless proved otherwise, is GI loss. So he has done that occult blood test, that was negative. He has done an endoscopy, he has done a colonoscopy, everything was negative. And so now this patient was again moving from another doctor to get his anemia corrected. So we had to convince him it is not iron deficiency anemia, because all hypochromic microcytic anemia are not iron deficiency. So in the first sight, he can make a diagnosis, but if he's not responding, you have to think of other causes also. So his ferritin was then, that is supposed to be the best investigation for iron deficiency anemia, is actually normal or even the upper side of normal. So iron deficiency anemia is ruled out. So now we have to go back to the automated hemogram again. So what is not fitting with iron deficiency anemia in this case? If you see the RBC count, it is near normal. So anemia normally we expect hemoglobin to be low. RBC count also should be low, but here it is near normal, around 4.68. So that is not point against. And very important thing is, in any anemia, that particularly hypochromic microcytic, next investigation you have to look is into the RDW. This is 14.4. So this is a normal RDW. What do you mean by this RDW? Red cell distribution width. So that means all the RBCs are of uniform size. They are homogeneous, which can never happen in iron deficiency anemia. Iron deficiency anemia, you'll have anisocytosis, poikilocytosis, pencil-shaped cells, cigar-shaped cells. All these cells, they will not be uniform. So the RDW will be grossly increased. That too, for this anemia of around 8.8, the RDW will be around 35 or 40. So his RDW is normal. That means this is hypochromic, no doubt, microcytic, no doubt, but homogeneous anemia. Iron deficiency is hypochromic, microcytic, heterogeneous anemia. So RDW should be increased. So if the physician has looked out into this RDW, he could have thought of some other diagnosis other than iron deficiency anemia. And another important thing is his platelet. We know in all iron deficiency anemia, you should have thrombocytosis because the simple fact that erythropoietin and thrombopoietin, they share the same homology. And erythropoietin will stimulate not only RBCs, progenitors, also the thrombocyte progenitors. So they'll have a thrombocytosis. So iron deficiency anemia, you should have a hypochromic anemia, microcytic anemia, heterogeneous RDW should be increased, and platelet should also be increased, and the RBC count should also be decreased. So superficially, though it looks like iron deficiency anemia, if you go into depth of the automated hemogram, it is not iron deficiency anemia. So what was done next? So a simple hemoglobin electrophoresis, which is not that much costly, around 500 to 600 rupees. Now this has picked up what is called as a thalassemia trait. This is common in our part of the Tamil Nadu. So we reside in Madurai, where we have got Saurashtra community, which is densely populated with Saurashtra. They have got thalassemia major, thalassemia minor, thalassemia trait. All these are quite possible. And he happened to hail from that community, and hemoglobin A2 is increased, which will be decreased in iron deficiency anemia, and he has got a thalassemia trait. So if the shrewd physician first making a diagnosis of iron deficiency, if he's not responding, you should have gone into the depth. Or if he's already well versed with this, if you go through the hemogram, he must have diagnosed thalassemia right to the first site. And so he was unnecessarily investigated very many times by very many physicians and given iron. Actually, they can go for iron overload if you unnecessarily give iron for this patient, because they have got increased absorption capacity of the iron. So they can go even for hemochromatosis. So this is the first thing which I want to highlight. So don't interpret anemia without automated complete hemogram, preferably 5 parts. Look at MCV. If it is hypochromic microcytic, look at RDW. If it is macrocytic, it's more than 95. Again, it can be B12 deficiency, folate deficiency. Or if the MCV is grossly 120, 130, the only diagnosis is autoimmune hemolytic anemia, where it is spurious macrocytosis. The RBCs will clump together, produce, it will be counted as single RBC by automated hemogram. Now, with the advent of this automated hemogram, my bone marrow biopsy procedure has come down drastically, because with the single hemogram, we can say whether the bone marrow is normal or not by the retic count. So when it's normochromic normocytic anemia, you look at the retic count, and there's a calculation for reticulocyte production index. And if the RPA is increased, that means bone marrow is good. It is able to produce. So need not do a bone marrow at all. You can avoid an invasive procedure. Only if the RPA is low, that means bone marrow is failing. Then you have to do a bone marrow aspiration or trephine biopsy to rule out aplastic anemia or leukemia or other causes, infiltrative disorders. So with that, if you are able to read the automated hemogram properly, you can clinch the diagnosis of any anemia without bone marrow. So indication for bone marrow only when the RPA, reticulocyte production index, is low, patient has got normochromic normocytic anemia. Otherwise, bone marrow has become a superfluous investigation nowadays. So all of you equip your lab or attach with the lab which has got an automated hemogram, preferably 5 parts for this anemia. That is the first case. That's a message which I want to deliver. Now, this is a second case. This is commonly seen, thrombocytopenia. So next, going to platelet, apart from RBC, there are very many things to discuss in RBC, but for the want of time, I am shifting to thrombocytopenia. So this is a fever, leukopenia, platelet of 9,000, no bleeding manifestation. Of course, it is dengue, because leukopenia, thrombocytopenia, fever, dengue has now become an endemic. So now, previously, what we are thinking is, the indication for platelet transfusion in dengue is whenever the patient has got bleeding, you have to transfuse. That still holds good, no doubt. The second indication was if the patient, even the patient has not got bleeding, and if the count is less than 10,000, that was an indication. Now we have revised that criteria. If the patient has got around 9,000 or 8,000 and is not bleeding, should we give transfusion or not? For that purpose, if you read in between lines automated hemogram, that will help you. What is that investigation? So for this case, we did a what is called as a IPF. So this is also now done in all the routine investigations in the automated hemogram. This immature platelet fraction, this is equal to a retic count for an RBC. If the IPF is good enough, that means the bone marrow is sufficiently and efficiently producing platelets to meet the destroyed. There are very many causes for thrombocytopenia and dengue. It can be because of bone marrow suppression, antiplatelet antibodies, splenic sequestration, capillary leakage, very many things. But the predominant factor is bone marrow suppression. But if the bone marrow IPF is good enough, that is normal is around less than 6. So if it is more than 6, the bone marrow is producing. So if it is 9,000 today evening itself or tomorrow morning itself will definitely become 15,000 or 20,000. There is no need for transfusion. So if the any dengue patient, though the count is low, and if his IPF is good enough, he can withhold transfusion. So we have seen even platelet count of one of hematologists was telling 0, but IPF was 40. So he didn't transfuse at all. So now you have to read in between lines automated hemogram in dengue patient, not only for leukopenia, not only for thrombocytopenia, but look for IPF because IPF is good enough, bone marrow is not suppressed. And one more investigation in the platelet is which we ignore, which is given in all the automated hemogram is mean platelet volume. So the normal mean platelet volume is around 6.5 to 12. And if the fresh platelets produced from the bone marrow, when they are increased in quantity, the mean platelet volume will be increased. So now we can classify the platelet thrombocytopenia with the high MPV. High MPV means it is because of the peripheral dissection. It is not because of bone marrow suppression. So you need not do a bone marrow biopsy when the patient has got thrombocytopenia with high MPV. This picture can happen in ITP also. So most of the ITP cases now where we don't do bone marrow because they'll have high MPV and increased IPF, they'll have thrombocytopenia. So that is, if low MPV means the problem is in the bone marrow. Low MPV, low IPF, then that's indication for bone marrow aspiration. It indicates bone marrow suppression. So similarly, when there's increase in the MPV and increase in the platelet count in the subsequent day by day, that means the patient, the recovery phase, bone marrow is improving. So with a simple automated hemogram, with the mean platelet volume and immature platelet fraction, you can find out where is the fault. It is because of peripheral dissection or because of bone marrow. So bone marrow again can be averted if you calculate and if you read the automatic hemogram efficiently. So this is yet another case related to complete hemogram, which we encountered in our GH itself. She was a 28-year-old female. She was admitted by EC fatigability. She had pallor, she had icterus, and urine output, RFT, everything was normal. And the patient had anemia and elevated indirect bilirubin, which was
ஒரு பட்டன் அமுத்துனா வர
of
மாட்டேங்குது.
hemolysis and elevated 564. And this patient was first investigated outside, and the direct Coombs test was positive naturally. And there's a young female with elevated indirect bilirubin and anemia with LDH, we are tempted to do DCT and it will be positive. If it is positive, we make a diagnosis of autoimmune hemolytic anemia. And with this positive DCT, the patient was started on steroid. And when the patient landed up to our GH, she was on steroid for 1 year and developed full-blown Cushing feature, Cushing-like phases, everything. Unfortunately, her hemoglobin didn't improve. So most of the autoimmune, they do some improvement with the steroids. If they don't respond to steroid, we have to think of different diagnosis. But the hitch is, it is positive DCT. No one will think of any other diagnosis. And when she landed in GH, what was anemia seen by the hematologist 1 year before has become pancytopenia. Hemoglobin, TC, platelet, everything was low, and MCV was 104. So that was a point that was not favoring autoimmune hemolytic anemia. As I told you, autoimmune hemolytic anemia, the RBC will be clumping together and such a clump will be counted as one RBC only. So the MC will be 130, 140. It's called spurious macrocytosis. And ESR again was near normal, CRP normal. So no point was favoring autoimmune hemolytic anemia and hypersegmented neutrophils. So we proceed with the bone marrow because we want to have a different diagnosis. It was suggestive of megaloblastic anemia. And where we went wrong, or where the first physician went wrong in interpreting the results. So, because first point is there was jaundice. Can jaundice happen in B12 deficiency? Yes, definitely it can happen. It is indirect bilirubin will be elevated. The mechanism is because of ineffective erythropoiesis, there will be intramedullary hemolysis. So that can be explained by B12 deficiency. So that was the reason why the patient had jaundice. Now the $1,000,000 question is why DCT was positive in this case. Now, so we went for reference and we found out that DCT positivity doesn't always mean autoimmune hemolytic anemia. It can also happen in B12 deficiency. And only the pattern of agglutination. If it is early and persistent agglutination, it is autoimmune hemolytic anemia. If it is late and transient agglutination, it is B12 deficiency. So that positive DCT, since the patient is not responding to your therapy, at least you should have revised and done the DCT again and try to find out the pattern. And so there are very many points against autoimmune anemia, where ultimately it was B12 deficiency. So both of them look alike, but these are the differences. Hemolysis at the bone marrow level in B12, it is at the intravascular site. LDH will be high, very high here. And MCP, which I told you already, Coombs is late positivity and early Coombs positivity here. Other external manifestations. So what links to actually is a clinical diagnosis. The patient had hyperpigmented creases. Despite hemoglobin of 6, the creases were hyperpigmented. So only we thought it could be B12. And this was eye-opener for us that positive DCT doesn't always mean autoimmune anemia. It can also happen in B12 deficiency. So we have to read in between lines in diagnosing autoimmune hemolytic anemia. And particularly when the patient is refractory to steroid therapy. So the next case in hematology is this was a 13-year-old female who had splenomegaly, pancytopenia, and ESR was 110. So now I'm going to concentrate on ESR, CRP. CRP was 3. So this is a mismatch. Normally ESR and CRP, they should get elevated concordantly. They go parallelly. When as a discordant, more of ESR and less of CRP, there are only very few possibilities. So first possibly you have to think it's SLE. So when there's the CRP is low, but ESR is high, the causes for mechanism for low CRP and SLE is because of hyperfiltration by the glomeruli and anti-CRP antibodies, drugs blocking, that is interleukin 6 blocking drugs like tocilizumab. And when CRP rises, this should not rise, but rises, you think of myositis or sometimes severe polycirrhosis. So when there's a mismatch between ESR and CRP, you first think in terms of SLE. That is an important clue. And when the ESR is more than 100, it can be divided into infections, connective tissue disorder, malignancy. On the infection, it is commonly osteomyelitis, urosepsis, tuberculosis, infective endocarditis, and abscess. And CRP is usually normal in dengue. That's a very important thing we have to note. And when there's a mismatch between ESR and CRP, one is SLE and in plasma cell dyscrasia also you can have such a picture. But it's the other way. It's the reverse, more of CRP and low ESR. It's more of an inflammatory, particularly infarction, that is HSCRP, high sensitive CRP will be elevated. And in ESR can be low in HLH also because the ESR is because of fibrinogen. So when the dengue patient develops a complication like HLH, they'll have a near normal ESR but elevated CRP. So we have to suspect HLS as a complication. So we have to analyze ESR. And one more important thing about ESR is ESR increases with the age. So as there's even there's a formula saying ESR is age plus 10. So if around 70 ESR in a 70-year-old female, you can even ignore it, not investigate it further. And ESR also gets increased in anemia, in renal failure, in pregnancy. So ESR is not that much important investigation unless if it's more than 100. If it is less than 100, you assess the clinical status and then give importance to ESR. And this was one case during COVID time. One of our VAP was admitted in our COVID ward, and he had severe dyspnea, cough expectation. Post that is after COVID, he was treated with the COVID routine steroids and tocilizumab also. His CRP was 0, but he had cough expectations. Sputum was green in color, and ultimately sputum was gram stain. It was negative, and Klebsiella pneumoniae was growing. Fortunately, we started in meropenem, and he recovered very well. But then we found out reference that whenever patient is on tocilizumab, it is going to interleukin 6 is going to inhibit the production of CRP. CRP is produced in the liver, and CRP can be even 0. So with the CRP 0, we should not think that patient is not suffering from infection, and we have to start the patient on antibiotic if the patient is on tocilizumab. So it can mislead you. And if you want to choose between ESR and CRP, CRP will be a better investigation because half-life is around 19 hours. So for serial monitoring, CRP will be a better investigation than ESR. ESR will take weeks to become normalized or to come down. So if you want to track the patient, it is ideal to monitor CRP level rather than ESR. And one more new investigation in CRP is called CRP velocity. So this is a newer investigation, a new biomarker for early detection. That is, if the patient comes to you on the first day, you measure the CRP. And the second, after 24 hours, you measure the CRP. That's called CRP2. And you find the difference between these CRP2 and CRP1 divided by the 24 hours. And the only prerequisite, patient should not be on antibiotic previously, before the first CRP value. And this is, suppose if this value CRP velocity is high, they are not given a definite cutoff. If it is high, we think in terms of bacterial infection. If it is low, you think in terms of viral infection. So now CRP velocity will be a better investigation than CRP alone, provided the patient was not on antibiotic before he reaches to you for giving the first sample. So this is one more information for the postgraduates. And now the one more thing, procalcitonin myth, which I want to break at least, because this is one case, a middle-aged male who has admitted he has got high-grade fever, vague pain abdomen, ESR was 88, CRP 56, total count 18,000, procal was 44, and he was started on meropenem because now we are now using all higher end antibiotic because very well available, and I will be given talk on even antibiotic abuse. Not to start an antibiotic even on the first day itself, or be justified in starting. Going through superficially doing investigation, we are reasonably justified because elevated ESR, CRP, total count, probably it is a bacterial infection, it is leukocytosis, and we have to start. But are we justified? His ultrasound abdomen revealed acute pancreatitis. The myth is we were thinking that procalcitonin is a marker for bacterial infection or sepsis, but that is not the fact. The actual fact is it is a marker for infection as well as inflammation. That means procalcitonin can be increased even in inflammatory condition without infection. So, and even in this medullary carcinoma of thyroid, it can go up to 1,000. So now with procalcitonin value alone, don't start the patient on antibiotic. It can be an inflammatory marker also. Now, where do you want to place procalcitonin in any infection? The only thing is you place it for de-escalating the antibiotic, not for diagnosing. So you start on meropenem, procalcitonin is 40. After the third day, it comes down to 10 or 8. And if the results comes as patient is sensitive to a narrow spectrum antibiotic, you can switch over to the narrow spectrum, stop the broad spectrum meropenem. So the only purpose of procalcitonin is for de-escalating the antibiotic, not for diagnosing. So that myth should be broken. And now moving from automated hemogram and some ESR, CRP, procal, will touch some enzymology on jaundice. So this was a patient who came for ICTRES, electrodesiccation. His LFT was 4.6, OT was 345, PT 179. He was a young male belonging to Tamil Nadu, that I have to underline. And unnecessarily, the physician has done all the viral markers, hepatitis B, hepatitis C, HIV, because that was serious enough hepatitis A. Everything was negative. So if you are a very shrewd physician, uh, you should have simply found out that OT is more than PT, which more or else rules out hepatitis. So in hepatitis, OT is a non-specific marker, enzyme marker. So it doesn't. It can come from liver, it can come from RBC, it can come from muscle, it can come from brain. So myocardium, empty number of sources are there. PT is specific for liver. So now this OT is more than PT, means there are other causes. Other causes. The only liver condition wherein OT will be more than PT will be alcoholism. Because for PT to get synthesized, you should have pyridoxine. That is pyridoxine that is inhibited in that is not available in alcoholic. So you'll have low PT. So if you are a shrewd physician, you should ask the attendants to go out of your chamber and ask the patient, did you consume alcohol? That too particularly binge alcohol. Binge alcohol is more than 4 drinks. Immediately you'll have alcoholic hepatitis. This is a picture. OT more than PT, not more than 400, unless it is foamy degeneration, alcoholic hepatitis, wherein it can go up to 1,000. So all these investigations are unnecessary. So OT more than PT. And if it is going to be viral hepatitis, it will run in thousands. Thousands. If it goes in thousands, there are only few conditions: acute viral hepatitis, ischemic hepatitis, autoimmune hepatitis, Wilson hepatitis, toxic hepatitis, or acute bile duct injury. So if it is more than 1,000. And what once we have learned is in dengue, OT is always more than PT. That is, in dengue, there's myositis, and that is the source. But in the recent past, we lost one case of dengue that's called expanded dengue syndrome, wherein the patient PT was more than OT. So that was an eye opener for us. OT is always more than PT in dengue, but if PT is more than OT in dengue, the mortality rate is 100%. The patient has developed expanded dengue syndrome, acute pulmonary hepatic failure, and we lost that patient. So by and large, OT is more than PT in dengue, but PT is more than OT, and all the clinical picture fits in with dengue. Still possible, but keep your finger crossed for prognosis. And other things very simple. LFT, tell the LFT, I'll tell the infection. So OT more than PT dengue. It isolated bilirubinemia, particularly direct, it is leptospirosis. So OT, PT more or less equal, but less than 400 scrub. In granulomatous hepatitis, you'll have isolated elevated alkaline phosphatase. Bilirubin will be normal, OTPT will be normal, low albumin, elevated alkaline phosphatase, it is granulomatous hepatitis, particularly common in tuberculosis. So with the LFT itself, we can more or less clinch the diagnosis without biopsy of the liver. So next, moving from some LFTs, we can touch upon something in nephrology. So this patient was a male bred to casualty in unconscious state. He was a known case of CAD, and pulse was Cori, BP Cori, and the investigation done was urea 176, creatinine 0.6. So one may be thinking, was it a lab error? Hemoglobin was 6 gram, and with this. The only diagnosed possible patient was presenting with shock with a disproportionate urea to creatinine. Normally, we know urea and creatinine, they should go in proportionate, 20:1. For urea 20, creatinine should be 1. For this urea 176 or 180, creatinine should be 9. But it is only 0.6. That means the disproportionate urea elevation. And the patient is in shock. Hemoglobin is low. The only diagnosis is UGI bleed. So we can by this UGA bleed. So it was drug-induced UGA bleed. He was on dual antiplatelet. So other causes for disproportionate urea, it can be UGA bleed, glucocorticoid therapy, tetracycline therapy, or HRS, hepatorenal syndrome. So when there's a disproportionate, more of urea, less of creatinine. The other way around, if the patient has got less of urea, more of creatinine, because urea is produced in the liver. So think of cirrhosis. Think of rhabdomyolysis, because creatinine will be more released. Think of hypoproteinemia or postperitoneal, because urea is more dialysable because of low molecular weight, 58 to 60. Creatinine has high molecular weight, 115. So these are the conditions. There's a disproportion between urea and creatinine. Think of all these things. And very important thing, which I'm going to highlight again, will be when the patient has got very low creatinine, it can be because of sarcopenia, pregnancy. Pregnancy, they have got increased glomerular filtration rate. So the creatinine will be around 0.6. Even 1.2 creatinine in a pregnancy, you have to view with suspicion whether it has developed acute kidney injury. A normal creatinine in pregnancy is probably not normal. We have to think twice before branding it normal. And this is yet another thing on RFT renal function test. Patient was an 80-year-old female. Patient person with shortness of breath and the urea 41, creatinine 1.1, hemoglobin 6. And this patient was unnecessarily investigated for anemia. Right to the first patient. Did all procedures and ultimately hemoglobin, they were not able to fix the cause for low hemoglobin. But if they have read in between lines the urea creatinine value, patient is 80-year-old, weighing only 46 kg. As I told you already, as age advances, creatinine should come down. Sarcopenia will be there. This 1.1 creatinine for 80-year-old female works out to a GFR of only 30 ml per minute. So now the important message which I would like to say in this forum is you equip all your just download app in your lab or ask your lab technician download that eGFR. Don't interpret creatinine value without eGFR. A 1 milligram creatinine of a 30-year-old male is not equal to 1 milligram of creatinine in an 80-year-old female. The GFR is 30. For a 30-year-old, the GFR will be 120. So a simple formula. What is the age, what is the sex, and what is the creatinine value? So if you feed that, it will give you the eGFR. So always interpret creatinine value with eGFR. Particularly as age advances, the creatinine should come down. If it is 1 or 1.1, it is equal to GFR of 30. It will be in CKD stage 4. So ultimately, the cause for anemia was renal anemia, and the unnecessary investigations were simple ultrasound aspect of that contracted kidney. But that was also ignored because they said creatinine is normal. This is not normal. 1.1 in 80-year-old, 46 kg female is absolutely abnormal. So this is renal origin. And this is my own classmate's daughter. And she was working in Canada, and she had some nocturnal itching and fever. She was afebrile, but for that mild dyspeptic symptoms, and she went to the consultant physician there in Canada. And this was everything was I had a video conference with her and got all these important things. Nothing abnormal in their physics. And there, like investigation done in Canada revealed bilirubin was elevated, alkaline phosphatase elevated, gamma glutamate transferase was elevated, but OTPT was elevated just border. It was not that much elevated. So this pattern will fit in with what we call it as a cholestatic pattern, cholestatic hepatitis pattern. So this is the pattern, but they have suggested probably it could be NAFLD, that is non-alcoholic fatty liver disease, or what is MASLD, now what's called MASLD. But she was not that much obese, so it's quite unlikely. And platelets are also normal. So fibrosis, everything, it's not possible. So she couldn't digest the diagnosis. And so she insisted on other investigations. As usual, all the investigation, viral markers were done, hepatitis B, A, E, everything was normal. Everything was normal. So it is not going to be a conventional viral hepatitis. So what was worrying her was, her and her physician was, because since it's a young female, OTPT elevation, why can't this be so-called autoimmune hepatitis? So this ANA investigation was done. Now this ANA is done left and right like ESR. So my important message about ANA is, unless it is indicated, don't do it, because it is almost positive in all cases. It can be positive in pregnancy, in tuberculosis, in any infection. And if at all, if you order for ANA, order for immunofluorescent pattern method. Don't go by ELISA. And you just interpret the result not only with the intensity, but also with the pattern, whether it is cytoplasmic pattern, nucleolar pattern, dense pattern, because each pattern has got its own value. And this patient had an intensity of 3+ with nucleolar pattern. And no, can you brand this patient as suffering from autoimmune hepatitis? Because ANA is positive, OTPT is subtly elevated, but cholestatic pattern. So that was a point against autoimmune. But anyhow, he landed up with this investigation to India, and we were not happy with the simple ANA. He landed up in Coimbatore to a gastroenterologist. He wanted the autoimmune panel to be done, and the autoimmune panel was absolutely normal. So now we are again back to square one. ANA is positive, but autoimmune panel, including anti-smooth muscle body, anti-mitochondrial antibody, that they are called for autoimmune hepatitis. These are the panel to be done. Everything is negative. Everything is negative. So still, is it possible to have autoimmune hepatitis in this case? So ultrasound normal. So because being a VIP, the gastroenterologist thought it could be a rare manifestation of primary biliary cirrhosis or primary sclerosing cholangitis. Both of them can have some cholestatic pattern. So MRCP was done. It was showed some mild cholestatic dilatation. That's all. And so he was not happy even with that. Ceruloplasmin was normal, and again biopsy was done, because since autoimmune hepatitis is still lingering in the corner, biopsy showed near normal but for intracellular cholestasis. Now we have exhausted all the investigations, starting from LFT to MRI, MRCP, liver biopsy, everything in this case. But what was missed in this case was, again, when I was presented in the history, she was a microbiologist, not a doctor microbiologist, but MSc microbiology in that category, working in a virology lab. So what we did is, we did an Epstein-Barr virus, because this can present as a persistent cholestatic pattern. And this was positive in that case. And when we inquired her, she said she was working with CMV virus and ABV virus for the past 6 months to 1 year, and it was a lab contamination. Now the question to be answered is why ANA was positive. So I told you ANA is such a naughty investigation, can be positive in almost most of the infections sometimes, and particularly in EBV. And this is the reference which we can read. Acute EBV infection or reactivation is correlated with presence of high ANA antibodies. So which gives you a notion that virus causes a dysregulation of the immune response towards self-antigen. So ANA can be transiently positive, but sometimes the patient is already harboring an SLE. This EBV infection can make the SLE become overt. What was occult can become overt. So be very cautious in interpreting an ANA investigation report. And in this scenario, if it is not going to be definitely viral hepatitis, your hepatotrophic conventional viral hepatitis, because OTPT never went more than 1,000, and it was cholestatic pattern. Cholestatic pattern is more common with hepatitis A. Commonly, if it is not that, you think of EBV and CMV. So a simple viral EBV test done probably at the end of that virus panel could have averted all the other unnecessary investigation, including an invasive liver biopsy. So that's an important message about this case. And this is, I think, this will be my last case presentation. This case was admitted in our GH only. He was a case of ITP diagnosed 1 month back. And because initially she was admitted with bleeding comes and thrombocytopenia only 3,000, and she was given the pulse dexamethasone therapy, and then she didn't respond to that, so we switched out to IV immunoglobulin, and still then the PET was around 20,000. Then with IV methylprednisolone, some it went up to 50,000. So at that stage, so we made a diagnosis of ITP refractory to steroid, started on IVIG, then increased the count up to 50,000. We discharged her. She was hailing from Dindigul, and we went home. And there, after 1 month, she had severe headache at one night, and she couldn't reach Madurai immediately. So she got admitted in Dindigul Medical College, where she was admitted with headache, seizures, and hemiplegia, left upper limb and lower limb for past 1 day. This was the scenario. And optic issue was not that much significant, and their platelet was 79,000. It was not that much low. Normally, when the patient with thrombocytopenia develops headache and seizures, we'll think of intracerebral hemorrhage, which was not the case in this situation. And all the viral markers, everything was negative. Routinely, we do for ITP stool for H. pylori. because that's one of the trigger for ITP. If it is positive, if you eradicate H. pylori, the ITP goes for remission. Everything was normal in this case, and CT brain revealed what is called as the CVT, cerebral venous thrombosis, that is hyperintensity in the parietal lobe. And this patient, she came with this diagnosis of critical CVT. So they have recognized CVT, and rightly the patient, they have started the patient on dexamethasone, mannitol, heparin. So all routine investigation with the anti-epileptic phenytoin. And with that previous treatment in the indical, so ITP patient developing CVT treated with the heparin, mannitol, dexamethasone at the indical GH, coming back again to Madurai with this for further treatment. We admitted her, and one of our PG was very shrewd enough, and she said this is a case of a paradox of thrombocytopenia with thrombosis. Patient initially had thrombocytopenia, that is one spectrum of the disease. Now he has developed thrombosis. So this is a paradox, or both, so we call it as oxymoron. Both things combining together. Only few conditions in medicine will have this combination. That is thrombocytopenia, thrombosis. And the patient being a female, she thought it can be a plus. Or the other possibility for such a combination will be HIT, heparin-induced thrombocytopenia, or can be WIT, vaccine-induced thrombocytopenia, or thrombotic thrombocytopenic purpura. So these are few conditions where you get this combination of thrombocytopenia, thrombosis. And she was right in making a diagnosis of APLA. And she sent for APLA profile, it was positive. So she presented this case as, so this is APLA. So shall we proceed with treatment for APLA with the high intensity anticoagulant? Once you brand any patient as APLA, it's going to be a lifelong treatment. They should be on high intensity anticoagulant, particularly warfarin, because NOVAC has not been very much studied in APLAs, and monitoring of prothrombin lifelong. But somehow something was not favoring APLAs in this case. So what was not favoring is APLAs, they don't present with bleeding diathesis. They present only with thrombosis. But initial presentation in this case was bleeding. And we increased the count to 52,000 with only drugs. So that was a point against APLAs. But so we went for other investigation for APLA, that is VDRL. VDRL is almost always false positive, but here it was non-reactive. And APTT. APTT will be prolonged. Any phospholipid-based investigation will be prolonged in APLA. That was also normal in this case. So now, having a case of thrombocytopenia treated with the IV immunoglobulin, steroid, we showed good improvement, developing thrombosis. Now APLA profile positive, but with all other comorbid APLA investigations become negative. We referred what are other causes for APLA positivity. Then we found out that current guidelines is patient should not be on heparin if you take sample for lupus anticoagulant. If the patient was on heparin in the preceding 12 hours, you will have false positive this lupus anticoagulant test, all the lupus anticoagulant tests. And our patient was on heparin because for CVT they started on Dindical and we are continuing heparin. So without that, we have submitted the patient unnecessary for APLAS, and we are about to brand the patient as suffering from APLAS and to start on lifelong, because once you start the therapy, another physician will not definitely stop. He will think twice because he should not be blamed. So now we have stopped the heparin and we repeated the APLAS test. It became totally normal. Totally normal. So the message conveyed is, before sending any investigation, you find out whether there are any contraindication for sending the investigation or whether the patient is on some drug that can alter the investigation. So now, what is the diagnosis? That is a different story. Now the main purpose is APLAS should not be sent when the APLAS should not be done, the patient is on heparin. Now, what is the diagnosis in this case? So then we went for reference, and it is because of immunoglobulin, IV immunoglobulin. So patient who was treated with IVIG for ITP, they can develop cerebral venous thrombosis. The mechanism can be because of this so-called sludging or inflammation of the vessel. There are very many mechanisms proposed, but there are case reports of cerebral venous thrombosis after intravenous immunoglobulin therapy in ITP. So that was the diagnosis. But the message which we are like to convey in this case is, APLA being a very costly investigation, don't unnecessarily do that. because the clinical scenario also doesn't fit in with, because patient presented first with bleeding, then with thrombosis. Apply the patient directly with arterial or venous thrombosis, though they can have thrombocytopenia. And patient should not be on heparin if you send for. So it was ITP treated with IVIG. And with that, again, because there are very many things to be discussed, probably you can have part 2 in this for discussion. With that, I stop my presentation on this, how to interpret the basic investigations and where, I won't say pitfalls, where we miss. So, and this is the thing we have to concentrate right from automated diagram, LFT, RFT, Uplas, ANA. So these are common investigations now done. And I'll be happy if we can ask some questions, and I'll thank again the organizer for giving me this wonderful opportunity. Thank you.
Sir,
thank you all.
Thank you very much, sir, for a wonderful presentation. It's a great, amazing presentation. I really admire your enthusiasm, involvement, and of course the dedication in collecting the investigations and finding out the important messages from the each investigations and given in a nutshell. Thank you very much for a wonderful presentation. And sir, you started with MCV and anemia. Excellent. All 10 cases were brilliant cases. And I start from the first case, MCV. If you have anemia, first you see whether following the rule of 3. If the RBC count is 5,000, the 5 into 3 is a 15 should be hemoglobin. If hemoglobin is 15, 15 into 3 PCV should be PCV. That is 45 should be PCV. If it is not following this rule, that means there is something abnormal. That is called some hemoglobinopathy. That's a one clue. So any person who comes with a low hemoglobin, you look for the rule of 3. 5 into 3, 15, 15 into 3, 45. That should be the RBC count, hemoglobin, and PCV. Right. Then you go to the MCV. Absolutely right. You go to MCV, whether it is iron deficiency, anemia, or that is macrocytic anemia. If MCV is low, hemoglobin is low, then immediately look for RDW, that is red cell distribution width. If MCV is low, hemoglobin is low, RBC distribution width is elevated, that is iron deficiency anemia. If RBC width is not elevated, it's normal, there you suspect thalassemia. There itself, the MCV and RBWC or RDW, if it is normal, MCV is low, it is thalassemia. You go to the other spectrum, MCV high, RBW high. MCV high, red cell distribution width is high, that means it is a pernicious anemia. MCV is high, RDW is normal, that means it's aplastic anemia. Then come to the other extreme. MCV is hemoglobin is low, MCV is normal, RDW is normal. That means anemia of there is a chronic disease. If MCV is normal, RDW is elevated, it is myelofibrosis. So you can diagnose myelofibrosis, aplastic anemia, pernicious anemia, thalassemia, iron deficiency anemia, everything in just single test. That's the again that's the second thing you told about the wonderful test that is called platelet abnormality, and of course you have given a very nice this case scenarios as well. The platelet abnormality is very, very important. That is immature platelet volume, immature platelet fraction. You see, as you rightly said, the reticulocyte count, when you see for anemia, you immediately look for reticulocyte count. That means whether bone marrow is normal or not. Whether bone marrow is normal, is a peripheral destruction there. That you have to see for anemia. Similarly, you should see the platelet, there is a immature platelet fraction. If immature platelet fraction is high, then as you rightly said, it is a bone marrow problem. Then you look for the bone marrow response to the platelet the synthesis. That and all very, very nicely explained. Then you go for there is a splenomegaly case scenario, splenomegaly, and of course one case what I said thought that is the last case ITP with you are going to steroid. The steroid it increases the coagulation abnormalities. So coagulation thrombosis can occur with the steroid by steroid itself, especially dexamethasone. So when your patient is on dexamethasone, they are prone for thrombosis, and probably that will trigger. As you rightly mentioned, any infection, especially viral infection and more so Epstein-Barr infection, it stimulates autoreactive antibodies. Probably the viral infection will trigger the autoreactive antibodies that ANA become positive in this case because of the this Epstein-Barr virus, because that will trigger. But one thing about the ANA is that the ANA may be positive even 3 to 4 years before the onset of the disease. So still could be SLE. That particular case still could be SLE because the ANA precedes by 2 to 3 years before the clinical presentation. And of course, this Epstein-Barr virus could have triggered the ANA, and probably in due course, if you follow the case, it probably turned maybe a SLE itself by itself. That's the thing. And so many other conditions, I think so, numerous conditions which are different mechanisms you have told very nicely. And regarding the HSP and CRP and ESR, so wonderful information. So whenever there is an infection, the CRP will be elevated. ESR is also elevated. As you rightly mentioned, CRP has got a short half-life and it goes rapidly and comes down rapidly. So in infections, CRP more appropriate to identify than ESR. Once ESR, it takes a long time to get elevated, and if it elevated, it get long time to get suppressed. So you go by the CRP, and CRP is a wonderful test, especially when they're considering with the infection. And also you talked about the procalcitonin. Yeah, procalcitonin, all procalcitonin elevated is not infection. Of course, the procalcitonin is a sign of infection and inflammation. One has to be considered along with the clinical scenario. And one more thing important, there's a LFT. LFT, the most important point is that whenever there is bilirubin elevation, we have got so many infections like malaria, typhoid, dengue, leptospirosis, scrub typhus. These are common infections where LFT derangements can occur. If you see the leukopenia and normal leukocyte count, the leukopenia with eosinopenia in the cell CBC, leukopenia, eosinopenia, CBC with enzyme elevation, it's only a typhoid. There will be eosinopenia, there are no eosinophils at all, or 1%, 2%, then most likely with the leukopenia, eosinopenia, it is the liver enzyme elevated, it is a typhoid. When there is neutrophil leukocytosis and the elevation of alkaline phosphatase in direct bilirubin, then the SGPT, SGOT marginally elevated, it is a leptospirosis and scrub typhus. If it is only enzyme SGPT or SGOT is elevated, it is probably a dengue virus. If it is bilirubin not elevated, only SGPT, SGOT elevated, again a dengue virus. In dengue viral infection, bilirubin will not be very much elevated, only SGPT, SGOT elevated. So many informations you have given, and because your 10 cases you have given, lot of information, new points, and what are commonly we miss in the investigations, that everything you have been mentioned about that. And one point about the dengue, I like to say that the early predictor of dengue, what you have done in our Kilpauk Medical College, there's just looking at APTT value. There are people, the dengue, they come with a low platelet count. Yes, there is not an indication unless the patient bleed. But what we found in our study was that any person who has a low platelet count, like 10,000 or 9,000, 8,000, immediately look, the first test is the APTT, activated partial thromboplastin time. If activated partial thromboplastin is elevated, platelet is low, these are potential candidate to bleed, might bleed in future. If APTT is normal or slightly elevated with severely low platelet, then that case is less likely to bleed, because we have done 800 patients in our Kilpauk Medical College. We observed that the inverse correlation of platelet count and APTT, that's given the clue for the complications that you have observed. So I think you have covered all the infections. You have covered most of the tests, the CBC, urea, creatinine, and LFT, and of course bone marrow assessment. All this is really is eye opener. And probably instead of going into the higher investigations, better we go and concentrate on the common investigation, look into this and screen it and just dissect it one by one. Probably we can find the diagnosis in the basic investigation itself. So wonderful presentation. Again, I admire and adore your presentation. I am really thankful to the wonderful learning today. Thank you very much, sir.
Thank you, sir. It was superb presentation from Professor, sir. Sir, shall we, sir, we will have, sir,
Introductions.
sir, we will have a word of wisdom from our President-elect Sridhar, sir. Sir, I made you as co-host, sir. Can you please give your words about the topic presented and your inputs about the topic, sir?
Thank you, Dr. Aruljothi. It has been a real eye-opener, and I think the whole thing has been approached from a different angle. See, when we started practicing in the late 70s, 80s, it was TC, ESR, hemoglobin, and such only urea, creatine, basic investigations. And mostly it was a clinical diagnosis with a stethoscope, palpation, auscultation, and such things. Even taking an ECG was a big thing in those days. But today, the investigations have reached such a pinnacle of height that we are able to deduce a lot of things just going through the results of investigations. But today's topic was different in the sense what meets your eye may not be the truth. What meets your eye may not be the truth. All that glitters is not gold. அப்படின்னு சொல்ற மாதிரி what meets your eye may not be the truth. And sometimes you have to read in between the lines as the topic itself says. And Natarajan sir has really done a great job. I think this will benefit the practitioners who have just started practicing. Not only those people, but also elders like me. Who thought, I never used to give much significance to the investigation. I used to go by more the clinical acumen. But today it was an eye-opener for people like me that so much could be read from an investigation. And that was further authenticated by what Dr. Paranthaman sir had to say, with the examples on dengue. So I think there's been a wonderful program, Arul. I congratulate you and Chairman Ashraf sir for choosing this particular topic.
Yes,
and
sir.
I'm sure in future he will come out with more such useful ones. Thank you, Arul. Over to you.
Thank you, sir. Thank you very much, sir. Sengatwan, sir, do you like to add anything, sir? Unmute பண்ணிடுங்க, sir, please.
Yes, thank you, Aruljothi. As Dr. Paranthaman pointed out, the CBC itself shows many of the diagnoses of infectious disease. As he rightly pointed out, eosinophilia, neutropenia, it's itself diagnosis of typhoid. So, in common viral, HVC, hemoglobin, and lymphocytosis are normal, and platelets be normal. It is a common viral disease. As he rightly pointed out that malaria is hemoglobin will be low, and monocytosis and platelets will be low. It indicates malaria. So he rightly pointed out, Dr. Paranthaman and Dr. Natarajan has elicited very clear points about and it is a really eye-opener for all the delegates who attended. Thank you for the opportunity given. Thank you, sir.
Thank you, sir. Thank you very much, sir. Paranthaman, sir, I have sent few questions I noted in the chat box. You can discuss, sir.
Yes. Can you read, sir? Because can you read out, sir, that chat question, sir?
One minute, sir. I will. How common aplastic anemia due to drugs in the present era, sir?
Absolutely, I think that's because we use a lot of newer drugs, and we do not mean using this drug before. These drugs have commonly seen, and there are especially the antiviral drugs and the monoclonal antibodies. Monoclonal antibodies, antiviral drugs, and rarely the antibiotics also, they present with aplastic anemia or they trigger aplastic anemia. These are drug-induced, and sometimes cephalosporins and penicillins and chloroquine. These are the drugs commonly advocated, but we do get aplastic anemia with infections and drug.
So, with your permission, one more thing to add is, automatically, I forgot to say, aplastic anemia, they will have pancytopenia. MCV will be around 100. So, around 100 pancytopenia, no organomegaly, no splenomegaly, no lymphadenopathy. the diagnosis more or less aplastic anemia. Of course, retic count will be low.
Absolutely. So if you have no spleen, the pancytopenia, it's only aplastic anemia.
Aplastic anemia.
If you feel spleen, it is not a aplastic anemia.
Right.
And as already mentioned, MCV will be elevated but RDW is normal. MCV elevated, RDW elevated, it is pernicious. MCV elevated, RDW normal, it is aplastic anemia. That's very clear. So and also splenomegaly will not be there. Will not be there. That's clear. Clinical presentation.
Sir, there is one more practical question related with the lab test. Like nowadays, healthcare industry is based upon insurance segments, sir. Like they used to tell to give report for X-ray. Like that, the lab report also they are telling doctors to attest. One question we got it from the chat that in such scenarios, is it safe to write in the bottom column of the lab report to correlate the report clinically? Can we like that?
That cannot be because, sir, so whatever the lab, they should say what the finding. So that we as a clinician, we correlate it clinically. Suppose the patient history of fever is there because he will not be given the fever history when taken a blood. So he has to give the finding. Suppose the reticulocyte is elevated, or spirocytes are seen, or abnormal teardrop cells are seen, or the microcytic what the picture is there, picture he has to describe. Once based on the picture, we clinically correlate whether this particular patient fit into it, rather than putting if you say it's a clinically correlate, they simply for everything they say it's a clinically. So we may not be giving the much value for the clinician. So they should give the impression based on that value. Then we have to clinically correlate it.
Okay, sir. There is another question. Will iron deficiency and anemia be associated with splenomegaly?
Iron deficiency anemia generally not, sir, because iron deficiency anemia is due to deficiency. It is suppose of malaria causing anemia, you'll have splenomegaly. If infections causing anemia, splenomegaly. Malignancy causing anemia, splenomegaly. But iron deficiency anemia usually not, because that is deficiency, and iron is necessary for the hemoglobin synthesis. So there is no way this thing get elevated. But in the case of infancy where the severe anemia, because of erythropoiesis in children, because the leukotic erythropoietic organs like a liver and spleen may be enlarged in children, but not in adult. In adult, if at all due to iron deficiency, iron this definitely not be elevated, but destruction like spirocytosis, elliptocytosis, hemolysis, and autoimmune, all these conditions may be spleen will be elevated.
As sir rightly pointed out, splenomegaly is not a feature of iron deficiency anemia, but young people or adolescents, 10% of them, so that is census statistics, can have splenomegaly. The only young people, because of the extramedullary erythropoiesis, erythropoiesis is going to stimulate, but iron will be deficient. So bone marrow will not be synthesizing much. So it will also stimulate the liver, stimulate the spleen. So in young individual or children, 10% can have splenomegaly. So that's quite rare. So it's very uncommon to have splenomegaly in iron deficiency anemia.
Yes, sir. Yes, sir. So there is one more question. What is the difference between red cell distribution with CV and red cell distribution with SD? What to consider while interpreting?
So CV is coefficient variant. SD is standard deviation. So each has got its own value. So one has got a value of around, which already focused, around 14 to 16. Another has got a value of around 30 to 40. So it is so we call a graph. The RBC is scattered and thrown into a graph, and they measure this two dimensions. So one has got both has to be considered, but both will go parallelly. When SD is elevated, CV also will be elevated. So one is coefficient variant, another is standard deviation. So standard deviation is for that particular group of individual. So coefficient variant is for that RBC, but that is all intrinsic hematology, but both of them will go hand in hand. The values are different. So one is around 14 to 16, 18, another is around 30 to 40. So if it is more, both of them will be get elevated, sir.
Yes, sir. Yes, sir. Fine, sir. One last question, sir. Can H. pylori can cause refractory iron deficiency anemia?
Definitely it can cause, sir, because Yes, sir. Please, you proceed, sir.
Yeah, yes. Definitely it can cause, because it is going to inhabitate the duodenum. So, iron is absorbed in the duodenum. So, it's one of the cause for malabsorption of iron, H. pylori. H. pylori can produce iron deficiency anemia, can produce ITP. So only I told all ITP, we do H. pylori screening and we treat for H. pylori if it's positive. And duodenum can be affected by H. pylori. So it can also, now iron deficiency anemia is more common after gastrectomy, after PGJ. So because after gastric bypass surgeries, so after H. pylori infection, B12 as well as, because we know intrinsic factors synthesized at that level. So H. pylori can produce a variety of problem: iron deficiency anemia, B12 deficiency anemia, ITP. So lots, sir.
Yes, sir. Similarly, that H. pylori decrease gastric pH, sir. But gastric pH should be good or the less for iron should be absorbed. So you need to, because it ferrous molecule has to convert to ferric molecule. For that you need acid. If acid is less, that conversion will not be there. So only it is converted, it get absorbed in the duodenum. So if this helicobacter infection, because of the alkaline pH, it decreases absorption of iron. That's one thing. And also, if you want to increase absorption of iron, you have to give vitamin C. Vitamin C, again an acid, that is vitamin C increase absorption of iron in the duodenum. So that's HB, definitely persistent HB infection can have persistent anemia. So that has to be addressed. Not only the anemia, B12 deficiency as Sir mentioned, and calcium also will be decreased. Calcium absorption will be decreased, magnesium absorption decreased, iron absorption decreased. HP is more common with all the deficiencies.
Yes, sir. Since both professors are here, a lot of practicing people are here. We will take 2-3 questions directly, sir, live.
Yeah, definitely. It's pleasure.
Yes, dear participant, you can unmute yourself and ask questions directly to Professor, sir. You can unmute and ask questions directly. We can have maximum 2 to 3 questions, not more than that. Okay, sir. No one is rising. They just texted. I will ask the question, sir, from that things.
Yes.
A few points about hepcidin, sir.
Hepcidin is a chronic inflammatory substance which is produced in the liver. It prevents absorption of the iron. It increases the binding. It decreases the binding capacity of the iron because the inflammatory marker, and there is a iron deficiency will be decreased. So even if you give elemental iron, because of the hepcidin is an inflammatory substance which is present in chronic infections, it will prevent iron absorption and prevents iron transport as well. So
one more thing, the important thing to add is in congestive cardiac failure, there's upregulation of hepcidin. So any congestive cardiac patient that got iron deficiency anemia, there's no point in giving oral iron because hepcidin is a negative iron regulator. It will not allow the iron to get absorbed. So all congestive cardiac failure with iron deficiency anemia, you should give only parenteral iron. Oral iron will not be absorbed because of hepcidin. And now up to date says, once you give iron tablet today, tomorrow itself hepcidin will increase. And so the next day iron tablet will not get absorbed. So now the current recommendation, though not come in textbooks, if oral iron therapy is better absorbed if you give on alternate days. So one day you give iron, next day hepcidin will be increased, the third day hepcidin will come down. So third day you give iron. So that is now going to be the probable future recommendation of iron therapy. Iron tablet, oral iron tablet should be given probably on alternate days so that hepcidin will not interfere with iron absorption. In all congestive cardiac failure patient, if they have got iron deficiency anemia, treat with the parenteral iron, not with the oral iron, because they are refractory to oral iron therapy. That's which I would like to add for that hepcidin, sir.
Yes, very nice point, sir. Again, the hepcidin is very anemia of chronic diseases. So hepcidin levels will be elevated in anemia of chronic diseases. Again, is an inflammatory marker which is produced in the liver. And there is one suggestion that when you read about the pregnancy, the role of oral iron and IV iron, there is no difference. If you give oral iron for 1 week, 1 gram will be elevated. If you give IV iron, 1 gram will be elevated after 1 week. So that's what the pregnancy. But the SAR says probably a new guideline is recommended from the up-to-date this thing. And this is the recommendations for the pregnancy. The iron absorption very much increased in pregnancy because of the need for iron. And also there is no significant difference between the levels of hemoglobin rise from the oral iron to the parental iron. That's what is a pregnancy. Maybe this may be a new point for us, sir. Yes, we'll concede.
Yes, sir. There is one more question, sir. We welcome our IMA State President, Sir Abul Hassan, sir. Abul Hassan, sir, are you online, sir?
Yeah.
Yes, sir. Please, sir, your words of wisdom and inputs about the topic to the crowd, sir.
Okay. Thank you.
Yes.
Thank you, Aruljothi, Dr. Singutun and the faculties. I was very unfortunate. I did miss this. Usually, I don't miss our meetings. All the meetings I attended. Today we had a very urgent meeting from call from headquarters. We had a meeting, just got over, regarding one important initiative, that is Junior Doctors Employment Bureau launching, that we had a discussion. I am very happy that this meeting, I just listened to some of the queries now, just 10 minutes or so. That and I could see that a large number of delegates attended this, and IMA Academic Committee is doing wonderful job. And there is kind of academic explosion that is happening in Tamil Nadu state, in the medical profession of Tamil Nadu. I'm very excited about it, very happy, and thank you, our academic committee. And we are, as we planned, we will be having a physical meeting of our academic committee the end of the year, and we'll be giving all the kind of gist of all meetings that happened over the years, so that the people and members will be immensely benefited. And I wish all the delegates and thank all the delegates who could share their time and energy and resources for improving our knowledge today. Thank you very much. Best wishes. Over to you, Dr. Aruljothi.
Thank you, sir. Thank you, sir. Ashraf, sir, are you online, sir? Sir is in the he's attending convocation for medical college in Tiruchi region. Okay, sir. Really, we appreciate all your participants. Your participation makes and gives more energy for us to conduct such activities. Thank you for your active participation. And before Ashraf, sir, are you online, sir? No. Okay, sir. Fine. Actually, we are not able.
Ashraf sir has sent a message in the chat box.
Okay, sir. Fine, sir. Fine, sir.
Thank you so much, President sir. Thank you so much, sir.
Thank you, sir. Thank you very much, President sir.
Thank you. Thank you very much. Wonderful, wonderful.
Yes,
and
sir.
the topic chosen also is very good today. Very, very innovative topic.
There are so many others in your batch who are excellent.
Sir, sorry, sir. 1 minute.
Okay.
We are technically evolving to reduce the noise. Yes, sir.
Thank you, Aruljothi. Thank you, Abul Hassan, Sridhar, Senguttu.
Thank you, sir. Thank you.
Dear participants, don't worry.
Thank you, academic committee, for an excellent presentation. Thank you so much, Ashraf sir. Thank you, sir.
Thank you, Sridhar. Thank you.
Good evening, Abu sir. Good evening.
Yes, sir. Sir, Vanakkam, sir. Dr. Sasiraj, sir, from Tanjavur, he will give vote of thanks, sir. Followed by, we will have short discussion, sir. Sasiraj, sir.
Yes, sir. Yes, sir.
Please, sir. Please.
Good evening, everybody. First, thanks to our speaker, Professor M.Natarajan, sir, for giving a very good lecture.
I request Honorable Dean, Professor Dr. Nehru, sir, to felicitate our guest of honor, Professor Dr. Ashraf, sir.
1 minute, sir. I will introduce it. Okay, done, sir. Fine. Please proceed.
Thanks to our speaker, Professor M.Natarajan, sir, for giving a very good lecture on third eye to see the unseen in investigations. His interpretation of investigations needs a great applause from everybody. Thank you, sir. Thanks to our moderator, Professor Paranthaman, sir, for providing us a vast knowledge in the field of hematology. Thank you, sir. Thanks to our IMA State President, Abul Hassan, sir, for supporting us in all the academic activities. Thank you, sir. Thanks to our Secretary, Dr. Karthik Prabhu, for giving us a friendly support every time when we need it. Thank you, sir. Thanks to our President-elect 2024, Dr. Senguttu, sir, Thanks to our President-elect, Dr. 2025, Dr. Sridhar sir. Thanks to our Chairman Ashraf sir for supporting us throughout the year. Thanks to Aruljothi for giving us a very nice Zoom presentation to all the bidding medical scholars who are going to be a part of IMA in the future. Thanks to Dr. Aruljothi for creating such a good academic activity throughout the year. Thanks, sir. Thanks to all the IMA Academic Committee members. Thanks to Mohammed Ibrahim for giving us the IMA prayer. Thanks to all the participants, around 400 participants this time. Thanks to all of you for joining us in this wonderful scientific session. Thank you, sir.
Thank you, dear participants. Thank you, sir. Thank you, Paranthaman sir. Thank you, Natarajan sir.
Thank you, sir. Thank you, sir.
Yes, sir. With your permission, I will edit the presentation and I will send a link to you, sir. After your inputs, we will release, sir. We are starting that work also, sir.
Oh, great. Sure, sir. Thank you, sir. Thank you, sir.
Thank you. Thank you very much.
Natarajan, sir, great presentation. Really enjoyed and really amazed by your nice presentation. And there are a lot of new points, a lot of information, new things I've learned. And Dr. Aruljothi, sir, it's a phenomenal interest in conducting such a program. And really, I'm very much amazed by your keen interest and dedication. Thank you very much. And Ashraf, sir, and all the tech faculties are very much involved in educating our people. Really great thing. Thank you very much, sir, for the wonderful opportunity.
Thank you, sir.
Thank you, sir. Thank you, Paranthaman, sir, because I feel at home whenever I'm with you. Thank you very much, sir. So we'll have some great association here afterwards.
Yes, definitely.
Thank you very much.
It's a pleasure, sir. Yeah, thank you, sir. Thank you, sir. Bye.
Bye.
Dear participants, just finishing message. Most of you know that whenever you attend online messages, you have to type your name, TNMC number, email ID, and mobile number in the chat box, because TNMC observer will be, they will consider these details as attendance for processing your credit point for these type of events. That's number one things. And a lot of new graduates and postgraduates as well as undergraduates after completion. You people are joining in these academic events. Please do follow these rules whenever you attend such meetings. And as Sasiraj sir told, we are having good ambience ecosystems in the IMA Tamil Nadu level. We thank state leaders as well as national level leaders and our academic committee members for all your involvement to make these events special. And as Ashraf sir told, by year end, we will try to release one book with the summary of all the CMEs we conducted. We will try to send hard copy to all IMA members. Another message I want to convey is a lot of non-IMA members are participating in these events. We request you to become an IMA member by contacting a nearby president or secretary in your area of practice to become IMA members for your benefit as well as for the association to strengthen our association membership number. Thank you. With that, we are ending the show. Thank you. Thank you very much.